Okay, we are here today to go through what physicians need to know about MACRA, but we're afraid to ask. We thank you for coming. First, we'll tell you a little bit about our firm, Garfunkel Wild. We'll then talk about what is MACRA, talk about performance, the advanced alternative payment model, and then if we have time, we'll of course go for some questions and answers, or at least we'll try to. Garfunkel Wild was founded over 30 years ago with a single purpose in mind: to attend to the specific business and legal needs of our clients in the healthcare industry. We represent one of the largest and most diverse groups of healthcare clients in the tri-state area. With nearly 100 attorneys in 4 different offices, we're consistently ranked in Tier 1 in healthcare by Chambers. Our newest office is in Albany, New York. As I said, have been with the firm since 1992. My colleague, James Deering, is here with me, and he, as with the other 2 partners resident in our Albany office, came to us straight through the Department of Health about 18 months ago, and we are thrilled to have them aboard with us. Let's dive right into Medicare pre-MACRA. Pre-MACRA Medicare was basically a volume system. The more you did, the more you got paid. You got paid on a per case basis or per CPT basis. Every time you did a service, you got paid. Every few years, though, Medicare decides to change the rules. We often look at it as a full employment act for lawyers and consultants, but pretty much confusing for everyone else. Historically, the fee-for-service system, clinicians are paid based upon volume or value, not necessarily value. Where physicians are paid on a percentage of collections, an RVU model, these are all value-based formulas. Volume-based formulas. We keep interchanging those words. My apologies. Historically, Medicare worked under what was called a sustainable growth rate. Well, this was basically established back in 1997 to control the cost of the Medicare program. The program was designed so if costs went up, the overall amount that could be paid stayed the same, but was divided among more things and more costs. So effectively, without Congress jumping in to make changes and put a freeze on what we call SGR, the sustainable growth rate, Medicare payments would go down. In 2015, if Congress had not enacted limits on this, which they called fixes, Medicare would have dropped down by 21%. So the whole concept behind MACRA is to try to fix this problem known as sustainable growth rate, which each year was temporarily fixed by Congress by not enabling the sustainable growth rate formula, which left the payment rates approximately where they were. Again, if that had gone into place, we would have seen a 21% decrease in Medicare payments. For some reason, most of the physicians would find that unacceptable. So then we come out with the new MACRA. Medicare Access and Chip Reauthorization Act of 2015 is now more of a value over volume based payment system. What it did was it repealed the SGR or sustainable growth methodology and creates a new reimbursement framework called Quality Payment Program, which is a merit-based incentive payment system. Basically, there are 2 different components of it, and we'll talk about both of them this morning. One is the merit-based incentive payment system, fondly known as MIPS, and the other is the advanced alternative payment models, or APMs. Basically, it creates a new reimbursement framework called Quality that rewards healthcare providers for quality of care and not just quantity. It affects how Medicare pays physicians and clinicians under Medicare Part B and is intended to change how physicians consume and order services of other providers in an effort to improve quality and enhance cost effectiveness. CMS estimates that between approximately 687,000 to 746,000 clinicians will be subject to the MIPS portion of this. The remainder, 30,000 to 90,000 eligible clinicians, will qualify for treatment in APM. So we'll talk a little bit more about what each of those are. CMS anticipates that these programs will accelerate adoption of healthcare information technology, as well as greater collaboration and integration efforts, resulting in increased consolidation among providers. What CMS has basically told us is that due to the cost to a practice group of implementing these programs, there is more of an incentive for groups to come together to decrease these reporting costs. Like other programs before it, everything works on a time delay. Information that providers submit in 2017 actually affects how much they will receive in payments in 2019. So the 2017 data that each physician submits now will determine what they get later on. The Quality Payment Program aims to do the following. By replacing the SGR, the Sustainable Growth Rate, it's supposed to provide some stability to the fee schedule rates. By moving the payment system to reward high-valued, patient-centered care, including promotion of adoption of the alternative payment models that align incentives across the healthcare marketplace, and replaces a patchwork of different quality programs, which we'll talk a little bit about in implementing the MIPS program. Basically, MIPS has 4 different components to it. 3 out of the 4 are just rejiggering of existing programs. For example, the Advanced Care Information replaces the Medicare Electronic Health Record program that was out there. Cost replaces the Value Modifier program, and Quality replaces the old PQRS program that was out there. Medicare hopes to have a smooth transition with this phase-in. And again, the real key here is what a physician does today is going to affect what they get in 2019. The key factor is for eligible clinicians to accept some risk, which is the whole difference between the MIPS program and the APM program. Under APM, they are eligible to receive greater bonuses, greater incentives than the MIPS, but it also means them taking on more risk. There's a fear that there'll be an increased cost to the MD, but we'll see what happens with that. The 4th element is a new element of clinical practice improvement activities, and Jim will talk a little bit about that, more about that later. So we'll jump right into MIPS, the Merit-Based Incentive Payment System. The eligible clinicians here are physicians, physician assistants, nurse practitioners, clinical nurse specialists, CRNAs, and in order to qualify, a clinician must bill more than $30,000 a year to the Medicare program and provide care for more than 100 Medicare patients a year. If they fail to meet either one of these tests, they will not be eligible to be within MIPS, and they will stay on the fee schedule. Now, well, as we'll see in a moment, the problem with that is they will not be eligible to receive the enhanced rates that MIPS provides. They'll also not be subject to the decreased rates that many providers will receive under MIPS who don't score above the 50 percentile in the MIPS criteria, which we'll get into in a moment. CMS has said that after the initial 3 years, they will open up participation probably to PTs and OTs, speech language pathologists, audiologists, nurse midwives, social workers, etc. So this is basically stage 1 of what we'll see growing to affect all payer levels. Again, you can participate, physicians can participate either individually or through their group practice. If they participate individually, they report on each of the different 4 categories on their own, just dealing with themselves. If they do it through a group, there's a report that goes in on behalf of the entire tax ID, and you report consistently either one way or the other. You either be treated as an individual or you get treated in a group. And there's truly an incentive to physicians with more than 30,000 and more than 100 patients, because this can greatly affect how much you get paid under the Medicare program. In 2017, as we'll see in a minute, what you submit here, there'll be in effect the 2019 payment, and there'll be a 4% differential, high and low, to see how much you get paid based upon where you qualify in the information submitted. Again, excluded positions include a physician that bills Medicare less than $30,000 a year or provides care for fewer than 100 Medicare enrollees. Also excludes newly enrolled Medicare clinicians and those people that are those physicians that qualify for participation in an advanced APM are excluded from MIPS as well. MIPS, the modified fee-for-service model, the fee schedule rate increases a little bit for each designated year. and then there's payment adjustments based upon performance. As we said, there are 4 categories. As people submit their criteria for each of these categories, they receive scores, which will then affect how much they get paid. Again, the system basically combines 3 existing systems: the PQRS, the value-based payment modifier, which goes to cost, and meaningful use through electronic health records, and adds a new performance category called clinical practice improvement activities. Jim will go into a little bit more about what that is later. MIPS provides clinicians the flexibility to choose the activities that they're graded on, and they can choose which criteria they submit in order to get the highest return rate they can in future years. This chart that's up in front of you shows that currently, under the physician fee schedule, there's a 0.5% increase in each year on the fee schedule through 2019. In 2019, we see MIPS coming in. Again, it's based upon the 2017 data that is submitted in each of these areas: quality, resource use, clinical practice improvement activities, and meaningful use of EHR technology. So in 2019, we see that the MIPS spread is 4%. That means at ground zero, if you come in straight in the middle, you will get a whatever the Medicare fee schedule is for that year. If you score high, you will receive up to 4% more than the Medicare fee schedule. And if you don't score high or choose not to submit at all, you're going to end up at 4% below the existing Medicare fee schedule. Just to put some numbers around that, if you do approximately $500,000 a year in Medicare business, if you stand to either gain in your Medicare reimbursement $20,000, which would be 4% either up, or $20,000 down, so you'll have a spread of $480,000 up to $520,000, depending on how your 2017 data goes. As we see, that eventually goes up to 9% starting in 2022, and that would produce on the same 500,000 a spread of 45,000 in either direction, or 90,000. So the idea here is, in order to enhance and get the highest reimbursement you can, you want to submit the information in MIPS so that you can score above the average, and that will allow you to get the highest reimbursement rate as things go forward. So we're going to talk a little bit about the different criteria. We're going to start with performance. MIPS is a performance-based program, and there are 4 performance categories: quality, again, that's the old PQRS, cost, clinical practice improvement activities, and advanced care information. And MIPS evaluates eligible clinicians using a composite score of how they do on each one of these areas. The 4 categories establish a composite performance score from either 0 up to 100, and that will be compared against a threshold and then used to determine physician positive, negative, or neutral payment adjustments. The whole idea here is it's supposed to be a neutral system where some people will go 4% up, some people will go 4% down. Obviously, our clients will want to go into the 4% up category. It's designed, other than certain bonuses that CMS has put into the pot, to be budget neutral, basically forming a bell curve. In the first year, the 2017 data, cost, one of those 4 categories, is not going to be taken into consideration. That won't go into consideration until 2018, affecting payment in 2020 rather than 2019. Performance, again, replaces the physician quality PQRS. There, we report at least 6 quality measures, including an outcome measure or high priority measure. Groups using web interface must report 15 quality measures. Performance in each measure will receive a certain amount of points. Each group will review and select the measures that best fit their practice. Again, like PQRS currently is, it always has a 2-year time lag. So the failure to submit data in any given year will affect what you receive 2 years later. Clinicians choose from a list of 300 plus measures, either individually or so before, from specialty measure sets designed for their group. And each physician must choose whether to participate in either individually or through a group model. They're incentivized to engage in improvement measures and activities that have a proven impact on patient health and safety. They give clinicians flexibility by eliminating certain redundant measures that were found to exist in the PQRS and allowing the clinicians to choose what's meaningful to their practice. An orthopedic practice may choose different measures than a radiology practice. And measures are set, all the measures are keyed into specialty, so they report which ones make the most sense. In order to be scored on certain measures, the clinician needs to meet at least a case minimum of 20 cases in those areas. So you just can't pick one, do one thing, and then get the highest score. You have to look to see which one of these actually reflect what your practice does. Failure to submit information on a required measure will result in a score of 0 on that measurement. And if you get 0 on all your measurements, you're going to be in that -4 category in the first year, and you're going to take a hit of approximately $20,000 on every $500,000 in Medicare business. So obviously, we want people to submit as much data as possible in the areas that will do them the best so that they can score the highest. Clinicians' performance is measured against benchmarks for the reported measures, and the specific benchmarks are computed based upon historical performance data during the baseline period, and if the data is not available, then the benchmark is determined prospectively. If someone submits more than 6 measures, CMS will take the top 6 scores, so there's no downside to submitting additional data in these areas. Each year, HHS will solicit new measures, and the annual list of quality measures will be republished, so each group is encouraged to continue to watch the new measures where they possibly can do best. And CMS will calculate 2 to 3 population health measures based upon practice size, which will all also go into this. Hey, I'm not sure what that was, but it was interesting. Somebody could show up and put on the mute, I guess. I don't know. So we're talking about the PQRS system is replaced. It replaces the value-based modifier. And again, there's no on cost, as we indicated before. Cost won't start counting until 2018. There's a new category of clinical practice improvement activities under which you attest that you've completed up to 4 improvement activities, 4 medium or 2 that are listed as high from a list of over 90 plus activities. And we'll give you some more information about where you can go to find these. They're all available through CMS on the websites. You got to basically, each provider needs to go in and see which ones best suit their practice. Smaller practices with fewer than 15 participants must attest that they've completed up to 2 activities for a minimum of 90 days to get full credit. The larger practices obviously have to submit more. MIPS advanced ATM clinicians receive full credit. Patient-centered medical homes also automatically receive full credit in these areas. There are also different specialties listed or different qualifications listed in this area for those patients that are referred to as, those practices are referred to as non-patient facing specialties, such as radiology, lab, pathology, where there's not really much face-to-face interaction between the clinician and the patient. There are different criteria that you can tie into to get higher ratings. Non-patient facing clinicians are only required to report 2 activities regardless of activity weight in order to receive full credit. The non-patient facing clinicians, a MIPS eligible clinician that performs fewer than 100 procedures with patient facing codes annually. So if you're doing less than 100 where there's patient interaction, you're going to fall into this non-patient facing specialty, which allows you to qualify for higher points or higher scores by submitting less data. Each thing that you submit has a different layer to it or different number of points to it. The idea is to maximize these points. The performance the Medicare EHR incentive program replaces the meaningful use program that we've all been familiar with. You got to fulfill the required measures: security risk, e-prescribing, providing patient access, sending summary of care, request and accept summary of care. All these things will give points to you so that you can maximize your scores under the MIPS program. Again, the idea is to maximize your score. That will enhance your rate. So once again, it is value over volume to show that you are adding value to the system, adding value to the service that's being rendered to the patient will increase your reimbursement rate under the Medicare program. And you'll be eligible for different bonuses based upon completing more data. Jim will get into a little bit more of that in a little while as far as during the 2017 year, how much data you actually need to submit. Under the advancing care information, you got to submit up to 9 measures for a minimum of 90 days for additional credit, and you may not need to submit ACI if the measures do not apply to you. So when you look at the measures for each one, they're very practice specific as far as specialty, and each practice needs to look to see where they fit in on these things. For bonus credit, you can report additional data, and there are all sorts of bonus categories that you can submit data in, which will serve to enhance or give you bonus points, which will lead to a higher score. A higher score obviously means a higher return on your Medicare dollar 2 years from now. Lastly, we've talked about you're going to get scores in 4 different areas. These scores are then given different weights to determine what your composite performance score is. So we see that in 2019, again, based upon 2017 data, the biggest element is quality. So we're going to be looking at the PQRS-like scores that went in 2017. So when you're choosing the categories on the list, you're going to center in on those quality measures because those will give you the highest return rate to get the highest amount going forward in 2019. Cost, although reported, and it's taken right off claim forms, will have no effect in 2019, but comes into play in 2020. Advanced care information, 25%, that stays constant, as does the clinical practice improvement activities stays constant as well. Percentages are for payment years. Performance years, again, are 2 years. Performance threshold. The CMS will set performance thresholds based upon the composite performance score for all MIPS eligible clinicians for a previous performance period. So basically, you're being compared to all the other physicians that are submitting data. So basically what happens is all these things come in, they're all weighted, the scores are then looked at, and you are then ranked essentially against your peers, the other physicians. Those that score highest will get the higher rates, as the chart we showed before, the 4% swing in 2019 versus a 9% swing in 2022. The higher you do, the better your score will be. There are certain minimum thresholds that during the first year, if you meet and get a certain number of points, you will arguably not receive any reduction, even if you are on the lower end, because CMS has put in additional monies so that those scoring low, as long as you submit data, you'll be eligible to either stay constant or move forward. Those that do not submit any data at all, though, will hit that negative 4% on their Medicare fees. So with that, I'm going to turn it over to Jim, who will take us a little bit more through the MIPS payment adjustments.
Great. Thank you, Hayden. So now we'll talk about the MIPS payment adjustments based on the performance threshold. As Hayden has stated, there's a 2-year gap between a performance year and a payment adjustment based on that year. For example, the payment adjustment for performance year 2017 made in 2019. In its most simple terms, clinicians who score at the threshold will receive no payment adjustment. Clinicians who score above the threshold will receive a positive payment adjustment on each Medicare Part B claim 2 years after the performance year. Likewise, clinicians who score below the threshold will receive a negative payment adjustment on each Medicare Part B claim 2 years after the performance year. The takeaway from this slide is that the rate adjustment is based on a linear sliding scale based on the composite performance scores of 0 to 100. As Hayden has mentioned, the performance threshold is set by CMS. So for scores above the threshold, the blue line, the greater the score, the greater the rate increase. And there's a dotted line that represents additional potential increases that we will discuss on the next slide. Scores below the performance threshold, you'll see the yellow line. The lower the score, the greater the reduction in rate. And clinicians or groups with scores from 0 to 1/4 of the performance threshold get the maximum downward adjustment for that year. As indicated on the prior slide, rate adjustment is based on a linear sliding scale using composite performance scores of 0 to 100. This slide shows the potential maximum adjustments. So for example, you'll see in 2019, a possible adjustment of a positive 4%, a corresponding negative 4%. Likewise for 2020, positive 5%, negative 5%, and so on. The upward adjustments listed have the potential of also increasing up to a factor of 3. However, that's highly unlikely. So for example, 2020, the positive 5% adjustment in theory could be positive 15%. However, CMS has indicated that's highly unlikely. It's because the program is budget neutral. Also, it's based on the overall distribution of performance scores. If a circumstance did exist where there could be a factored adjustment, it would be based on the degree to which a composite performance score exceeded the performance threshold. So in addition, you'll see on the slide the blue area at the top for exceptional performance. For years 2019 through 2024, CMS has allocated $500 million for each of those years for exceptional performers that reach an even higher performance threshold. So you'll see the dotted line on top of the green squares. That's a higher performance threshold. That's also based on a linear sliding scale depending on how much the composite performance score exceeds the performance threshold. So that increase for exceptional performance can result in an increase ranging from 0.05% to a maximum of 10% for a composite performance score of 100. As Hayden has mentioned, clinicians can participate in MIPS as an individual or a group, but you must choose to report on an individual or group basis consistently across all MIPS performance categories. If you're reporting as an individual, you would send your MIPS data in as an individual, and your payment adjustment would be based on your performance. An individual is defined as a single national provider identifier, NPI, tied to a single taxpayer identification number, TIN. And you'd send your individual data for each of the MIPS categories through an electronic health record, registry, or a qualified clinical data registry. You may also send in quality data through your routine Medicare claims process. If reporting as a group, you would send in your MIPS data as a group, and the payment adjustment would be based on the group's performance. A group is defined as a set of clinicians identified by their NPIs, sharing a common taxpayer identification number, no matter the specialty or practice site. The group will send in group-level data for each of the MIPS performance categories through either the CMS web interface or the mechanisms that we listed for individuals. To submit data through the CMS web interface, you must register as a group by June 30th, 2017. So the data submission process. This slide lists the mechanisms which we listed and will provide you some additional information regarding them. Qualified Clinical Data Registry, or a QCDR, is a CMS-approved entity, such as a specialty society or regional health collaborative that collects clinical data on behalf of clinicians for data submission. It is different from a qualified registry in that its purpose is broader than submitting data to CMS. By comparison, a qualified registry is an entity that collects clinical data from an individual MIPS clinician or a group practice and submits it to CMS on behalf of the clinicians. And clinicians obviously would work directly with their chosen registry to submit data on the selected measures or specialty set of measures. with regard to the CMS web interface, it's only for groups of 25 or more clinicians. And for groups that elect to include the Consumer Assessment of Healthcare Provider Systems survey as a quality measure, they must use a CMS-approved survey vendor. You'll also see on the slide the reference to attestations. Those relate to attesting that you have completed certain improvement activities. This slide shows the process in determining a MIPS payment adjustment, and we have another slide later in the presentation that also shows that, and we'll go into more detail on that. So what we've been describing so far is essentially fee-for-service reimbursement. And there are other payment models called alternative payment models, or APMs. An alternative payment model is a payment approach developed in partnership with the clinician community that provides added incentives to clinicians to provide high quality and cost-efficient care while taking on more financial risk. APMs can apply to a specific clinical condition, a care episode, or a population. APMs can offer significant opportunities to eligible clinicians who are not immediately able or prepared to take on the additional risk and requirements of advanced APMs, which is the second option in the quality payment program. So to not make things more confusing, but with regard to the quality payment program, we have MIPS, which we've been talking about, and we also have advanced alternative payment models. However, in MIPS, there's also alternative payment models that aren't advanced, and that's what we're talking about now. And it's important to understand that the quality payment program does not change the design of any particular APM. Instead, it creates extra incentives for participation in APMs. This slide provides the legal definition of APMs. Some examples of what they are accountable care organizations, patient-centered medical homes, and bundled payment models. In order to be a MIPS APM, which is a subclass of APMs, the APM has to meet certain criteria. Number one, the APM entity must participate under an agreement with CMS. It must have one or more MIPS eligible clinicians on an APM participation list, and the APM must base payment incentives for performance on cost or utilization and quality measures. The benefit of participating in a MIPS APM is that they have special rules for MIPS scoring designed to give performance credit, and there are also reduced reporting burdens. Now moving to the separate path of the quality payment program, moving out of MIPS and into advanced alternative payment models. So there's an additional type of APM called an advanced APM. And again, this is one of the two MACRA QPP options of MIPS or advanced APMs. An advanced alternative payment model, or an advanced APM, enables clinicians and practices to earn greater rewards for taking on some risk related to their patients' outcomes. An advanced APM must meet the following criteria. Number one, base payment on quality measures comparable to those in MIPS. However, unlike MIPS, there is no minimum number of quality measures, except that an advanced APM must have at least one outcome measure unless there is not an appropriate outcome measure available under MIPS. Two, an advanced APM must require the use of certified electronic health record technology. So in doing that, an advanced APM must require at least 50% of the eligible clinicians in each APM entity to use certified electronic health record technology to document and communicate clinical care. The threshold will increase to 75% after the first year. The third requirement to be an advanced APM is the entity must either, one, bear more than nominal financial risk for monetary loss, or two, be a medical home model expanded under CMS Center for Medicare and Medicaid Innovation Authority. While these requirements give some perspective on aspects of an advanced APM, you won't have to figure out if an entity qualifies as an advanced APM. CMS tells us and lists those on its website. We also have a list of those entities on an upcoming slide. In addition to an APM needing to qualify as an advanced APM, participants must qualify as well. To be a qualifying participant or a QP, you must have a certain percentage of your patients or payments through an advanced APM. So looking at this chart, for year 2017, the requirement is that a clinician have either 25% of his or her Medicare payments through an advanced APM or 20% of Medicare patients through an advanced APM. For performance years 2017 and 2018, the participation requirements only apply to Medicare payments and patients. Starting in performance year 2019, clinicians may also meet an alternative standard for advanced APMs that will include non-Medicare payments and patients. Qualifying patient determinations are made at the advanced APM entity level. All participating eligible clinicians are assessed together. That is, for an advanced APM entity, CMS will evaluate the aggregate experience of all eligible clinicians in that entity and determine whether that aggregate experience meets the threshold. If the threshold is met, then all eligible clinicians associated with that entity are considered qualifying participants. So getting back to what are the advantages to being in an advanced APM under the Quality Payment Program. QPs who have sufficient participation in an advanced APM can qualify to be exempt from MIPS payment adjustments. So you'll remember, while there's the potential for upward payment adjustments, there's also the potential for downward payment adjustments. So participants in advanced APMs don't have to worry about those downward payment adjustments under MACRA. QPs also receive an APM incentive payment, and that's a 5% lump sum for the payment years 2019 through 2024, in addition to the payment impact of participating in the APM directly. So, for example, if the APM offers a shared savings or shared losses, that's separate and in addition to the components of MACRA. Beginning in 2026, QPs will receive a 0.75% physician fee schedule payment rate increase compared to a 0.25% increase for eligible clinicians participating in MIPS. Here are the list of advanced APMs for 2017. They're listed on CMS's website, qpp.cms.gov, and the list will be updated by CMS as it makes additions, and it's currently contemplating some additions for the list. So when does the Quality Payment Program start? If you were ready, it started on January 1, 2017. If you weren't ready, it can start anywhere between January 1 and October 2nd, 2017. Performance data must be sent in by March 31, 2018, and the first payment adjustment based on performance goes into effect on January 1, 2019. So what does this mean? We'll explain it with some more slides. Here's the QPP timeline. So the first area of the timeline is the performance year. So the performance period opens on January 1, 2017, and it closes on December 31, 2017. Performance data, as we mentioned, must be sent in by March 31, 2018. Then there's a feedback period during which Medicare provides feedback about your performance after you send in your data, and it will also calculate adjustments And those payment adjustments, as previously mentioned, are made 2 years later. They're made in 2019. CMS received a lot of pushback with regard to the initiation of MACRA on January 1, 2017. The final rule was not complete or finalized until the fall of 2016. So there was a push with CMS by legislators and others to change implementation to 2018. CMS did not choose to do that, and instead it developed an implementation plan called Pick Your Pace, which provides options for participation during the first year. The options are these. Number one, don't participate at all. And if there's no participation in the quality payment program for this transition year, it will result in a negative 4% payment adjustment of Medicare Part B claims in 2019. The second option is a test pace. So submit some data after January 1st, and you can get a neutral or no adjustment. If you submit a minimum amount of data, 2017 data to Medicare, for example, one quality measure or one improvement activity, you can avoid a downward adjustment, have a neutral adjustment. The next option is submit data for a partial year. So report for a 90-day period after January 1, 2017, and potentially get a small positive payment adjustment in 2019. So what this means is if you were not ready on January 1, you can choose to start any time between January 1 and October 2, 2017. Wherever you choose to start, you'll need to send in your performance data by March 31, 2018. The next option is participate for a full year. So fully participate starting January 1, 2017, and that can result in the greatest possible positive payment adjustment. If you submit a full year of 2017 data to Medicare, you can earn either a moderate adjustment or otherwise. The best way to earn the largest positive adjustment is to participate fully in the program by submitting information in all of the MIPS performance categories. And another option outside of MIPS is to participate in an advanced alternative payment model, which we've discussed. Here's a graphic depicting the pick your pace options. Not participating, getting a negative adjustment, submitting something, getting a neutral adjustment, submitting for a partial year, potentially receiving a modest adjustment, and submitting for a full year and getting the greatest adjustment possible. CMS also received pushback or feedback regarding the difficulty of implementing MACRA for small and rural clinicians in particular. A small group constitutes 15 or fewer clinicians. Because implementation of MACRA may be more challenging for small or rural practices, CMS has some special rules for them. For example, in the clinical improvement activities area, requiring one high-weighted activity as opposed to two, or two medium activities as opposed to four. In addition, MACRA also provides that small and solo practices may join virtual groups and combine their MIPS reporting. However, that option will not be available for the 2017 transition year, but will be in the future. To also address the difficulties that will be faced by small and rural practices, CMS is providing some monies and technical support to help. There's a $20 million a year allocation for a 5-year period totaling $100 million to provide technical assistance to practices with 15 or fewer eligible clinicians participating in MIPS. This is intended to assist practices in a successful transition into the MIPS payment pathway, and priority will be given to practices in rural areas, health professional shortage areas, and medically underserved areas. Also, there's the Transforming Clinical Practice Initiative. Information about that can be obtained on the CMS website. What can you do now? You can learn more about the basics of MACRA. You can do that by visiting their website, qpp.cms.gov. Second, you can determine your eligibility status. So do you have Medicare billings of $30,000 or more? Do you have Medicare patients of 100 or more? And are you in your first year of Medicare? Next, you can use CMS's QPP website to review which measures and activities best fit your practice. In addition, CMS publishes a mid-year and annual quality and resource use report to help practices understand their cost assessments under the ValueBased Modifier and quality under PQRS. You can review those reports to identify where improvements can be made. Next, determine how you will report, whether as an individual or a group. Also, evaluate your electronic health record and vendor readiness. To evaluate that, you can check that your EHR is certified by the National Coordinator for Health Information Technology. If it is, it should be ready to capture information for the MIPS Advancing Care Information category and certain measures for the quality category. In addition, consider using a registry to extract and submit data. And of course, if you have any questions, contact your Garfunkel Wild attorney.
Okay, that basically brings us to the end of our slides. In brief summary, what we'd just like to say is that most physicians out there will qualify for the MIPS payment system under MACRA, which basically takes 4 areas: quality, cost, advanced care information, clinical practice improvement activities, 3 of which are old, 1 of which is new, and requires that the physician or the physician's practice submit data in each of these areas. Some will come straight from the claim forms. Some the physicians will have to put in by certification. Others will be gleaned from the billing records themselves. Then each physician or physician group will receive scores based upon that material, and where those scores put them as compared to other physicians submitting will determine where they fall in a spectrum, which will determine whether they get an increase above the Medicare fee-for-service rate for that year, remain neutral, or a decrease. By doing nothing, you can guarantee yourself that you will receive a decrease. By submitting minimal data, especially in the first couple of years, you'll be either neutral or a slight increase. And the more data you submit, again, as Jim pointed out, you have to submit for at least a 90-day window, which is why it's the October 2nd date, because that gives you 90 days to the end of the year. You will guarantee yourself either remaining neutral or going up. That about concludes our presentation. Our bios and contact information are listed at the end of the slides, and we thank you for joining us this morning. And there we go. And we'll see if there's any questions in the queue. If we can figure out how to do that. And I see that as of right now, we don't have any questions listed. So I want to thank everybody for joining us this afternoon. And again, if you have questions, feel free to reach out to either Jim or I, and we look forward to trying to answer them for you. Thank you.